opportunity to invite Dr. Hany Ragy, who's come from Egypt, Cairo, and he's one of the renowned interventional cardiologists in the Middle East, and he's got so much teaching which he has done, and he's pursuing the primary PCI program in his region of the world very passionately. And it's a pleasure to have you with us today. So, over to you, sir.
Thank you so much for the kind introduction, Dr. Mato, and thank you so much for the kind invitation. And big greetings from an ancient country of Egypt to a very ancient country of India, and to everybody in this room and to all my friends. I present two cases today, and they were both done quite recently. The first case, the level of difficulty was more in the patients than in the lesion. So this was a 77-year-old female who was uncontrolled diabetic. Usually her hemoglobin A1C would be above 9, who was super frail, looked much older than her age, always brought in on a wheelchair. She was immobile due to orthopedic issues. Her LDL was 129 on maximum statins. She was hypertensive, resistant hypertension with a systolic 160 on most of the time on triple therapy. She had stable angina in 2018, and a CT angio was not done due to calcification in the thousands. In 2022, she developed severe angina, even though she almost doesn't move. She lives between her bedroom and her bathroom. She was brought to CCU. She had a troponin positive diagnostic angio, and we crossed over radial. After learning from Mamas many years ago, I'm an exclusive radialist since 2012, but I didn't work in this lady due to some arm problems, so we shifted to, say, femoral. She had severe 3-vessel disease, which I'm going to share with you now, including mid-LAD, long calcific segment. Her LAD, all the way to the apex, was like a thread. It was so tiny and diffusely diseased. She had a proximal left circumflex focal lesion, which I'll show you in a minute, ostial PDA stenosis. She, pour la forme, as they say in French. She was referred to CABG. She was turned down by the surgeons due to the non-graftable nature of the distal LAD and to the frailty and the immobility, and she would have refused CABG anyway. This is the safe femoral, and this is an AP cranial view. You can see that the left main and the proximal LAD look okay. Actually, later on IVUS, they were full of, and you can see, look at the distal LAD. I mean, after it bifurcates with a diagonal, you can see that the LAD is tiny, but it goes all the way to the apex. In this view, you can probably appreciate more that the LAD is, the distal LAD is almost non-existent. It's a very small artery, less than 1 millimeter. Again, here, you can see the distal LAD, a very small artery in a small woman, in a small diabetic woman. Here it is. So that was a diagnostic angio. That was his RCA, and she had a PDA focal lesion here. We decided to treat her medically. She was too sick, and that was her preference. She did well for 3 months. She was asymptomatic. Then she developed a bout of severe diarrhea and vomiting. She was COVID negative. She developed severe acute coronary syndrome. She was brought back to the CCU with a troponin 600, which is our lab limit is 15, with major anterior wave ST depression. We tried to stabilize her for 3 days in the CCU, totally failed with needing to use large doses of intravenous nitroglycerin. She also had access. We allowed her to use sublingual nitro because she was like psychologically dependent on it. And she used, we had to stop her because she was putting in too many pills. The heart team and the surgeon accepted the case based on the old angio because she was dying, basically. We couldn't do anything. But she refused surgery, and she asked for either PCI, she's fully conscious, or discharge against medical advice. She said, I'm not going to have surgery, just send me home to die. So we took her to the cath lab. for PCI. Her RCA looked the same. The left system this time showed, if you look here, let me play that again. Okay, if you look here, there's a gap. There's almost subtotal occlusion. It's actually worse. So we know that we have a culprit lesion. Her circumflex focal lesion looked worse, but could be an element of spasm. And of course, her distal LAD is something that you can barely see. Again, this is the disease extending all the way. And you can see the angiographic calcium before we even put IVUS. We did use IVUS. And please note, if you're treating this case, where would you want to land your distal stent? Because the reason I had the rotablator ready in case the reason was the lesion was uncrossable, but I decided that I'm not going to rota if this is a crossable lesion with a balloon, because I was worried that my rota would slide past the lesion and something would happen and I would need to go beyond the bifurcation. I was planning to stop here, but planning to use IVUS to see if this was a good landing zone. And geographically, I thought the landing zone just before the LAD bifurcates into the tiny thread-like LAD and the larger diagonal would be a good landing zone. And as with all angioplasty, the best thing is to prepare. So we wired the LAD with a lot of friction on a standard wire. This is a run through, and it went in with a lot of friction. I could feel the friction, but there was no problem. And I had a visual impression that the flow was even worse. We encountered severe. This is a 1.5 balloon. They have a make in that hospital which has 2 dots, which I was surprised to see. And the angiographic calcium was very severe. We had a lot of balloon friction, but we could cross. It was not uncrossable. So a lot of pre-dilatation with a 1.5 balloon. And here we decided to, if we work, we're going to land our stent here. Note that the patient is moving. I had an anesthetist in the room based on that hospital protocol. I normally sedate patients myself. He was very unhelpful. He was very, very good, but he was unhelpful because the patient was so fragile. He says, I don't really want to put her into any form of deep sedation because if I put the tube down this lady's, if she goes on a ventilator, she's probably not going to come off it. So he was unhelpful. He kept her like dizzy, but she could move, which was annoying. I couldn't pass the IVUS probe after the 1.5 balloon. The IVUS, I'm using a Volcano and it's bulky. So went in with more PTCA with a 2.5 balloon. Again, you'll see her chin moving. And this is after dilatation. I'm trying never to go beyond the planned landing zone. Now the artery seems better, so we IVUSed. We passed the wire then. I hadn't passed the wire till that point, but now passed the wire into the diagonal. You can see the dissection. And then we IVUSed, and it showed, and I'll show you IVUS picture, it showed a cracked and dissected artery, but with very heavy calcification. So we decided to IVL. We gave her 30 pulses here and 30 pulses proximally because I wanted to keep some pulses cost-wise for the circumflex in case I need it. I don't need to show you diagrams of the IVL, but you're aware of it. The balloon, you use the proper size balloon, and you give your pulses to crack the calcium proximally. And after exhaustive lesion preparation, it looked okay. This is the IVUS. After the lesion preparation, you'll see a lot of gunge, and you see a lot of calcium, but it's all cracked. And we went in with the stent as planned, just covering our distal landing zone, hoping that we won't have any edge dissections. Stent size based on the IVUS, which was successful after IVL. The stent was not covering the proximal edge. This is just before the stent is deployed. You can see that we're missing the proximal edge here. So we'll need, we put a second proximal stent, and both stents were checked by IVUS. Please note the size discrepancy between, by the way, this is all full of plaque, all the way to the left main, but, you know, we decided to leave it and give her major lipid lowering because it looked angiographically okay. And this is the area which has been fixed. Please note the distal LAD. I mean, you really don't want to go down there. This is her post-procedure. I do have a run. This is her angio post-procedure. And her LAD is filling right to the bottom. You can see it here. This is a still frame. This is a run. I don't know if it will play. The stent is reasonably well deployed, and you'll see some plaque proximal to it, which we decided to leave untreated before we reach the left main. And we then used the IVL first. I don't have the picture for the circumflex just in case, just anyway, because we had it open on table. Then a pre-dilatation, and then IVUS, stent, IVUS post-dilatation, and we had a very good outcome of the circumflex, which was really simple. And it did not need the IVL, by the way. I just used it because it was there. And I was so happy with the way, the difference in feeling of friction after, when I had friction with the wire, I had friction with 1.5 balloon. But after the IVL, I could put a 28 millimeter, a 3 by 28 millimeter in calcium with zero friction. It just glided through. And I know from the presentation, which was given earlier by Dr. Punamia, that you know, this kind of planning will probably save you a lot of restenosis rate later. Those, just a reminder of on the left of what her arteries looked like, on the right of her repair. This is the last slide. This patient was discharged 48 hours later. She's only been followed up for a month now. This was a new procedure. It's completely uneventful, zero angina pectoris. I believe IVL is a game changer. And while Dr. Punayama was responding to a question here about costs, and he said something very pertinent, which if he allows me, I would like to repeat. If you're not ready with the armamentarium for fighting calcium because of cost or anything else, don't take this war. Just don't do it. If you don't have a four-wheel car, and you see very wet sands, don't drive in with your two-wheeler. You're going to get stuck. And once you're stuck, you know, your patient will suffer because it's not you. So you have to have the full armamentarium with calcium. And I know, of course, that places like Fortis, which are worldwide pioneers for new technology, have everything. For us in Egypt, it's actually more difficult. IVL is a game changer. It allows us to optimize IVUS-guided PCI in heavily calcified coronary arteries, where we initially had severe friction on simple wire, on hydrophilic wire advancement. We could easily advance large stents with zero friction. We anticipate better long-term outcomes in addition to improved acute and cath lab results. And I think IVL, beside IVUS, we're all, fortunately, in this room, big IVUS, rotablator. Beside rotablator, we're all big rotablator users. So I think IVL is a useful tool. I wouldn't have been happy with the rotablator in this case because I think touching the distal RCA might have got me in trouble. And I'm very happy to be here again, and thank you very much, and happy to take questions.
Just do IVL and DEB.
Sorry, say that again.
Just IVL and just do DEB, full DEB rather than putting a
drug-eluting balloon.
stent, drug-eluting balloon. And do you have access to OPN balloon in your country?
I have access to OPN balloon, and I use OPN balloon to sometimes up to 50 bar. And again, as the slide, I learned a lot today. I've limited my OPN balloon now to in-century stenosis. And I have quite a few tips and tricks about OPN balloon, by the way. And one of them, if you use a big OPN balloon, a 3.5, and you go up to 50 bar, and you're working radial in a 6 French caster, be ready for the balloon to fail to go back into the guiding caster, and it might even tear if you pull it. So use dilute contrast and be extremely slow in deflating it. Give it enough time, and you might end up pulling the entire system if it just doesn't go back into the guide. They become extremely bulky after 50 bar. Yes, I use OPN. I don't dare. No, we have a lot of DCB, and I use the proper DCB as well, the ones with the data, because there are many DCB which have some powder on a balloon, which might not work. But the DCB with the trials are important. But I wouldn't dare use. I mean, like this patient, I don't want to see this patient in a cath lab again. To be honest. To be very honest with you, I was hoping during the 3 months in which I didn't see her that she'd go to somebody else. Okay, but she came back.
Actually, I have one question. When you said that when you're passing wire, you had a lot of friction while passing wire and balloon. So why you tried pre-dilatation? Why not to go directly with rotablation or IVL?
Thank you very much. I could not pass the balloons easily, and the IVL balloon is actually very bulky. And
Rota, I mean to say rota.
You said rota or IVL.
You could have done rota.
I explained why I didn't use the rota. I'm actually very happy to use rota, and I had the rota ready. But I was worried because the last very calcific part of the lesion was right at the bifurcation, at the landing zone where I would put my distal stent. And I felt I needed the precision of the dots of the markers in the IVL, and I did not want to put any hardware down what looked to my eyes a ½ millimeter. By the way, the IVUS couldn't go down there, down the distal LED. I mean, there was a channel taking blood down that distal LED all the way to the apex, but it is so incredibly diffusely diseased. I was worried that my rota, you know, when your rota pops, would go down there. I didn't know what it would do. Maybe nothing, but I did not want to put any hardware down that distal LED. And the nice thing about this strategy, it actually worked. Landing
sometimes the guide extension works. If the IVL balloon is bulky, perhaps sometimes you have to use guide extension. That can help to deliver the IVL.
But you know, it worked in the end, and the patient, even with that distal LED, which I thought, I'm sure if I put an FFR down, that distal LED is going to be ischemic. But because it doesn't move, she's
calcified lesions, pre-dilatation sometimes can produce very bad spiral dissections.
Yes,
so
it's true.
Very bad spiral dissections. So you have to be very cautious. Doing rota later is sometimes becomes very difficult.
I was only planning to use rota if this was an uncrossable lesion. Even if I had a very bad spiral dissection, I would have IVL'd and stented. It would have worked.
Dr. Praveen, can we put this rota wire of like distal LED like this? Because so much of diffusely disease where the simple new wire fails to go, and it created a lot of friction.
Yes.
It could be a difficult task for the rota wire also to reach the area.
The new rota wires would probably cross, but you know, after I put the hydrophilic, the run through, which is everybody knows the run through is like a brilliant wire. Down there, like you said, I mean, I would have been unhappy to exchange and do a rota. I was, like I said, I had a plan, and the plan worked. And of course, in PCI, you know, if you fail to plan, you're planning to fail. And if your plan works, if your plan A doesn't work, maybe you can go to B. But our plan A here worked. And our plan A was no rota unless uncrossable, okay, or undilatable. But it was crossable and it was dilatable.
Thank you very much, Dr. Ragy. This was an excellent presentation.